All right, we are now live on Facebook. We will give everyone a moment to join us. Give everybody a good second to join us here as we're live on Facebook with a very special guest today. So just give everyone a second. We are honored to have Dr. Rashawn Ray join us today. So we're going to give everyone a moment, Doctor, and then we will get started.
Sounds great.
We'll just let people build in. I hope that everyone is well in your family. I hope that everyone listening and their families are well as we deal with this continuing crisis. So thank you for joining us. We'll give everyone another minute and we will get started.
Sounds great. It's my pleasure to be here.
Thank you. Thank you for having us. Thank you. Thank you for being here. All right. Good evening, everybody. To everyone joining us, good evening. Good evening. Thank you for joining us tonight. Another 60 seconds and we will get started. Another 60 seconds and we will get started. I like the books you had behind you there, man.
I appreciate that. Yeah, Stephanie and I, we were talking about, I'm a professor, so I love books. I have tons of books, and typically my desk is facing a window, or the window is behind me. Obviously, in this era, that can't happen. People can't ever see me when I do stuff like this. So, shifted around to the best part of the office, and here we go. Get to show off some books.
All right. Good. All right. So we are going to get started. Welcome everyone to another briefing with Brandon, where we've been discussing what you need to know about COVID-19. If it's your first time tuning in, I am Council President Brandon Scott. Today is Monday, April 27th. I'm coming to you right after a city council meeting. We are honored today to have Dr. Rashawn Ray, a David M. Rubenstein Fellow at the Brookings Institution, here to talk to us tonight about reducing COVID-19 racial health disparities. But before we do that, as always, I want to first start out by checking in and giving you guys the numbers and want everyone to understand that it's easy to tune out and stop hearing these and only think about them as numbers. But we have to remember these are lives, these are humans, these are families, and we all have a role to play in stopping the spread of COVID-19, especially for our seniors and people with compromised immune systems or pre-existing conditions. So to that end, we now have 19,487 cases in the state of Maryland, 858 deaths statewide, a confirmed count of 1,933 in Baltimore City with 82 confirmed cases. We still, 21215 is still the zip code in Baltimore with the most cases, 337 by 21218 with 169. Remember, everyone, you can always go to coronavirus.baltimorecity.gov or coronavirus.maryland.gov for the latest information and the breakdown of data about zip code, race, and all these other things that we've been advocating for. I want to mention this again today. We talked about it yesterday at our last briefing that the reports of people in their 30s and 40s with COVID who are dying of strokes connected to COVID-19, as reported by the Washington Post. These are otherwise healthy, young, or middle-aged people. So please, please, please understand again that anyone can contract COVID. Really quickly, I want to go through some city council recap before we turn it over to the good doctor. Tonight, I introduced a bill that would provide renter relief. Whereas we know that we are a city that have a large population of renter, we must consider their needs deeply. And when you don't know where your next check is coming from, you shouldn't have this stress about your landlord raising rent during the biggest health and economic emergency of our lifetime. So I introduced that legislation that would prohibit rents from being raised in the city of Baltimore during this COVID emergency. We also passed a resolution to a state of emergency extension. This is a crucial, as the city council had to pass this resolution in order to allow the mayor to extend the state of emergency due to COVID. The mayor can only call a state of emergency for up to 30 days. And since the council, we understood that this is an important moment, we went and voted for that, and that was approved tonight. The Children and Youth Fund. We passed something very significant tonight. You've heard me say time and time again to everyone that when they ask about the digital divide and computers, that I was working on something. Tonight, the city council, we passed a bill that allows and creates the permanent fiscal home for the Children and Youth Fund, but also it allows us to do a one-time use for COVID-related expenses. We're going to use that $3 million of the Children and Youth Fund to go towards breaking down the digital divide and supporting the school system and reaching out and being able to help our young people learn in the digital way. Also, 6 million to help with food access in Baltimore, something that we uplifted in our COVID document. We cannot expect that our young people will have access to the computers and to keep up with their studies during this pandemic. We need to keep in mind that these computers are not just for the older children, but also for the kids who are learning in those critical learning years with the odds already stacked against them to begin with. This will be the only time that I would consider dipping into a fund, the youth fund, but we have to do it because right now we're in a crisis and we know food access and the digital divide are things that our young people need help with right now today. Quickly, very quickly, Tuesday, tomorrow at 6:30, the Health Committee will hold a second informational hearing on a resolution that I introduced, Baltimore Strategic Response to Coronavirus. The first hearing was on March the 5th. We'll hear from our health department tomorrow. You can watch on Charm TV. We will be asking tough questions about how we're doing contract tracing, how we're focusing on zip codes, how we're going to talk to the African American community, how we're going to ramp up testing. Make sure that you tune in for that tomorrow night, and Thursday at 11 a.m. The Taxation, Finance, and Economic Development Committee will have an information hearing on implementing the Water Accountability and Equity Act, a piece of legislation we champion that will change and make the way we do water bills more equitable in considering income. And we know how important that is during a crisis like this. So now, everyone, now we got that out the way. To welcome to this briefing, Dr. Rashawn Ray. Good doctor, thank you for joining us this evening. Thank you for coming and talking to us about this most important topic, but also want to uplift with you and allow you to introduce yourself for those of you who don't know who you are. Introduce yourself to the good people here and talk about your work before we get into some questions for you.
Well, City Council President Scott, I really, really appreciate the opportunity to be here this evening. As you mentioned, I am a David Rubenstein Fellow at the Brookings Institution in Washington, D.C., and then I am also an Associate Professor of Sociology at the University of Maryland in College Park. So I'm actually right down the road, come up to Baltimore all the time, raising my kids here, really consider the corridor between Baltimore and D.C. to be my home. I also co-edit Context Magazine, Sociology for the Public, and I'm the executive director of the Lab for Applied Social Science Research, we call it LASER, at the University of Maryland, where we do innovative research, particularly related to layering up virtual reality for law enforcement to improve decision making.
Yeah, thank you. Thank you. Doctor, you wrote two articles for the Brookings Institution that caught my attention. Why are Blacks dying at higher rates from COVID-19 and how to reduce the racial gap in COVID-19 deaths? That's what I want to talk to you about tonight. But I want to also give you an opportunity to share about any of your other work and what you have done as a scholar and someone who thinks deeply about issues of race, health, and our society. But I want you to start off by giving us a sense of how COVID-19 is affecting Black, white, and Latinx communities differently. Why are African American and Latinx communities particularly vulnerable to COVID-19?
Yeah, well, as you mentioned, I wrote these pieces at Brookings. People can just go to brookings.edu, search my name, they'll pop up. You could probably also just put it in Google. And one of the things that I really try to highlight that I think caught people's attention is the role that structure plays in undergirding pre-existing health conditions. So we know, particularly as it relates to Black Americans, that Black Americans are more likely to suffer from diabetes, heart disease, high blood pressure. And oftentimes we attribute those particular outcomes to people's behavior. However, research shows that it's not people's behavior, nor is it something in Black people's blood or Latino folks' blood that some kind of way manifests a higher likelihood of contracting COVID 19. Instead, it has to do with our structural location. So if we look in Baltimore, for example, and we take a map of the city of Baltimore, we could take a map of Baltimore from 100 years ago and overlay it on top of the map from today. And what we would see is if we do a correlation with race, we'll see that the correlation between a map 100 years ago matches a map today. That's because, unfortunately, our neighborhoods are still highly segregated. Part of what that means then is that there is a legacy of redlining. And of course, Baltimore City has one of the most horrific histories of redlining that has restricted the ability for Black neighborhoods and then, of course, minority neighborhoods from gaining access to capital for businesses and the like. What this means for people today in 2020 with COVID-19 is that Blacks live in neighborhoods in Baltimore, whether it be kind of the northern side of the city or the western part of the city, that are more likely to live in neighborhoods with a lack of healthcare access. What that means is lack of access to get to a hospital, meaning you have to go farther to get to a hospital. And as you know, when it's rush hour traffic or even when it's not traffic, minutes can actually dictate life or death. Second, they are less likely to have specialty places in their neighborhoods, meaning specialty places to get treatment. They are also less likely to have pharmacies. If they do have pharmacies, they're less likely to be stocked. So what that means right now during COVID-19, they go to a doctor, they get treated, they went to the ER, they get prescribed medication, they come back, and then all of a sudden, they try to get that prescription filled and they can't. It turns to 2, 3, and 4 days that they might not necessarily have. Second, we know that Blacks are more likely to live in neighborhoods that have less access to healthy foods. What this means is fewer grocery stores, fewer healthy food options, fewer places where they can buy fresh fruits and vegetables. One of the big things I've been saying is if you have $10 in your pocket, this is for people who always think that behavior is what's determining what's going on. But I will say that it's interesting how we juxtapose the difference between, say, people being at a cookout or at a house party and we do the people being on the beach. Neither of the groups are social distancing, but it's interesting how we frame them based on race. But part of what this means is if you have $10 in your pocket and you're trying to feed a family of 4, are you going to go to the Whole Foods that doesn't exist in your neighborhood, or are you going to go to the McDonald's on the corner? I think everyone will make the same decision. The final 2 parts deal with exercise and work. Blacks are less likely to live in neighborhoods that have recreational spaces, green spaces, lighting, safety, and these sort of things that foster the fact that people are engaging in physical activity. I studied this a lot when I was a Robert Wood Johnson Foundation scholar at UC Berkeley. Final thing, of course, we know Blacks are more likely to work in these new essential jobs, working as cashiers, store clerks, baggers, transportation in terms of driving vehicles, driving buses, driving trains, working in custodial jobs, working in healthcare. Blacks represent about 20 to 25% of all of these new essential jobs. When you put all this together, this means that Blacks are more likely to be exposed, more likely to contract, and then more likely to die from COVID-19.
Yeah, I think, and listen, doctor, I think that you hit the nail on the head. And for those in Baltimore who are watching, and when he talked about this is something, doctor, that's personal for me, because as you may know, 2 years ago I introduced and passed what is now Baltimore's racial equity law, and I talked about specifically how Baltimore was the birthplace of housing redlining via legislation, and you can look at what Mr. Preston did then and see how we are now, decades and decades later, still living in a city with this deep structural inequality. And the only way to undo inequality and racism that was done via policy is through policy. And that's why it's so critically important. And when you talk about like the new essential workers, for me, actually, it's as personal as it can get, with my mom being a giant worker in a giant in the zip code in the city with the highest cases, and knowing the risk that she's facing each and every day. And that leads me into my next question for you. Many of us know the phrase, when America catches a cold, Black people get the flu. You updated this in 2020 by saying when America catches coronavirus, Black people die. Uh, can you explain that and try to help people understand why Black people are not just more prone to catch coronavirus, but more likely to die from it, and how everything that we've been talking about plays into that, the death rate for us also.
Yeah, I mean, first off, I mean, I'll be praying for your mother, like I pray for, all frontline workers. As I mentioned, I mean, including my wife, who's a healthcare provider. I mean, I really don't think people understand the gravity of what they're going through, putting their lives on the line. I know we'll get to solutions in a bit, but I think it's a series of solutions that's really big for workers. So I think when it comes to why we're dying, I think it's two things to look at. I've talked about the structural conditions, but I think it's another layer to that. Then I'll talk about healthcare access and healthcare quality. When it comes to um, when it comes to living in certain neighborhoods, we are not only living in structurally deprived places, but that then means we are further exposed to pollutants. I think a lot of people know about Flint, but as you know, President, one of the things that's interesting is that in Baltimore, there are some neighborhoods and zip codes that have extremely high levels of lead as well. People don't really understand what lead does to your body. What lead does to you is that not only does it impact the insides of your body and literally kills it in a lot of ways, but it can lead to physical deformities. If it leads to physical deformities, imagine what it's done on the inside of your body. Mentally, it impacts critical thinking, it impacts academic achievement, people's ability to focus. And research shows that lead has deleterious impacts on these pre existing health conditions that we mentioned. Now, the other part of this deals with healthcare access and quality. I went through access a little while ago. Let's talk about quality. One interesting thing about quality is that when Black people go to the physician, we're oftentimes spoken to instead of spoken with. Those are two very different types of scenarios. For a lot of people who are white,
Yes.
they're so accustomed to healthcare providers, police officers, firefighters, teachers speaking with them, that the fact that somebody is now saying that somebody is speaking to you and at you are two very, very different things. I describe it like this because oftentimes people want that the end result is this, that Blacks are less likely to utilize healthcare because they are less likely to obtain equitable treatment in healthcare. It's not that Black people are just opting out. It's the fact that we are literally being mistreated. I think about it like this. You go to a restaurant, say I come up to Baltimore and you like, hey Ray, you gotta go to this restaurant. This is the spot. And I'm like, okay, all right, President Scott said it, I'm gonna check it out. So I go eat and the food isn't good, the service is bad. I'm like, okay, well, Brandon said it was dope. Let me go back again. So I go back. Service is bad again, food isn't good again. Guess what? I'm not gonna go back. That's what happens to everyone in life. And unfortunately, that's more likely to happen to Black people in healthcare. I think it's one big stat that is one of the saddest stats in the United States. And that's the fact that Black women are more likely to die when delivering babies. This should be the most enjoyable day of their lives. But yet and still, part of this has to do with the fact that healthcare providers perceive that Black people have a higher pain tolerance, perceive that our blood doesn't coagulate in the same way, perceive that we have thicker blood. All of these things play together that actually lead to women like Serena Williams and Beyonce reporting that they actually experienced an episode where they might have died after they had children. These are two of the fittest women that we have on the planet. And so when we
And that's the access and the money that most women don't have in our community.
exactly. I mean, so finances is not an issue. Health is not an issue. Instead, it deals with some other things. There was a study that I want to talk about briefly, then make my final points on this. There was a study that asked healthcare providers on a scale from 1 to 10, how much pain medication would you administer to these patients, right? Same patient profile. Only difference was that some of the patients were Black, some were white. Healthcare providers were less likely to administer pain medication when both sets of patients said that their pain on a scale of 1 to 10 was an 8. That's the type of way that this plays out. This then leads to medical mistrust that is valid. Studies show that Black men who know about the Tuskegee syphilis study are less likely to utilize healthcare. Of course, we could think about Tuskegee, we could think about Henrietta Lacks, both studies, of course, which happened at Hopkins in Baltimore. It shouldn't be a surprise why Black people in Baltimore feel the way they do about healthcare, which then means in this era with COVID-19, when we call in to seek help and we go in to try to get help, we're more likely to be sent home. When we call in to seek help, we're less likely to be listened to. This leads to the likelihood that we're going to be sent home to die alone. It leads to the likelihood that we're not going to get the medication we need. Those are the structural factors that, as you mentioned, that policy can really address to deal with this racial gap.
Yeah, thank you. I think that's a critical point that people miss sometimes, right? You can't when you've been done wrong over and over and over and over and over again, you're not just gonna go back and say, yes, help me, right? You can't get rid of that historical and that trauma really that we've seen. You talk about some other structural issues really quickly, and then I want to get to some solutions with you about housing and transportation. Can you talk about this from this perspective of your work?
About housing and transportation.
Yeah, and
So
how
when it
this has
comes to
helped.
housing, one of the big things we know, and we even seen this, unfortunately, something that went viral where we know that Black people are more likely to live in densely populated areas. I mean, we seen this, unfortunately, when a police officer came by a neighborhood in an apartment complex and started coughing out. You
Right.
know, these are the types of things that further erode trust that we don't necessarily need at this time period. So part of what this means structurally is that Blacks are more likely to live in spaces with more people. So by the time a person tries to get out of their apartment, get in their vehicle, oftentimes don't have a vehicle, oftentimes walk into a bus stop, walk into a train stop, they've passed 50 other people who were doing the same thing. So I want to give an ideal type. Let's take a woman, a woman, say, who works with your mother, but who stays on the other side of the city. She comes out of her apartment. There are a lot of people around. She goes then to get on a bus, right? And in a lot of cities, the bus routes as well as the train routes have been running on a limited schedule. This is
Hmm.
an example of where a positive policy became an indirect outcome for inequality. Of course, what policymakers are trying to do is to say, hey, you know, we're going to make sure that people can engage in social distancing. Well, social distancing is a privilege. Depending on where you live, you can't engage in social distancing. So now what you've done, like in New York, you've loaded it up where tons of people are on a train together, and you can, like I'm going to work on Monday morning at Brookings, you can smell someone's breath beside you. That's not what we need during the pandemic. So when it comes to housing, Black people are living in spaces where they can't social distance. When it comes to transportation, then the limited schedule might actually be exposing them more to the virus, which then means they have now went across the city trying to get to work, trying to get to a job, mind you, that oftentimes doesn't have health benefits, doesn't have hazard pay, doesn't have sick leave. So what that means is they're going to go to work, because if they don't go to work, they won't get paid. And now they're at work sick, interacting with other people where they contracted it at, and then getting back on public transportation, bringing it back to their communities and their neighborhoods. That's how we see Black neighborhoods and Black zip codes being harder hit.
Yeah, thank you. I think that's a critical thing, and we have to understand that. I talked about that ad nauseum about the inability for certain neighborhoods, and I'll be talking about that with our health department tomorrow night at our hearing. The inability in certain households and neighborhoods for people to practice social distancing because it's either they're going to practice social distancing or not go to work, and we
Yep.
can't, and they have to provide for their families. So,
Yep.
thank you for all this work and all this information you've given us thus far. But I want to ask you some other questions. How do you think cities can start to move to reduce the racial health gap, especially in consideration of COVID-19?
Yeah, I mean that this is the key question. I think it's a few things that I outline in the part two that you mentioned at Brookings. First, we need demographic data. Part of getting demographic data means we need more testing. Let me break each of those down. This doesn't simply mean that we get it race. We also get it place. And I know from the work I've done, race and place are highly correlated. Anyone living in Baltimore City should know that. Shouldn't even be a question. And we talked about the historical remnants of that. So we also need information on age, on gender, as well as health information on pre-existing health conditions. And then we need to get social scientists like myself who analyze these data to be able to say what is the likelihood of these sort of things going on, because it's not a catch-all. People who are living in the north side of the city or closer to downtown might have a different health profile to contracting COVID-19 than someone who lives, say, on the far west side of the city. So demographic data does that. Second main point with testing is that testing has to be ramped up and it has to be equitable across the city. What we've seen in most cities is that testing is primarily situated where hospitals are, where outreach facilities are, where these types of facilities are where people can go urgent care. Well, we just talked about the fact that Black neighborhoods, low income neighborhoods, are less likely to have these sort of things. So part of what that means then is that city governments, state governments must allocate testing facilities to be in predominantly Black neighborhoods. And one of the things I'll argue is that Black churches become a primary venue for this. Pretty much no matter what neighborhood you go into around the country. I went to grad school in Indiana University. It was 4% Black. You could find a Black church and a Black barbershop there. Like, it doesn't mean that they cut hair well, but it does mean that they were there. And so you can scale that up in all those different places where you can set up Black churches in similar ways to what President Obama called promise zones, what we call it in public health, or health equity zones. We already know the churches are handing out food. They're trying to give kids laptops. They're bringing in homeless. Layer this up with testing. They have the parking. They have the facilities on the inside for triage. These sort of things will speed it up. And it's one very, very important reason, in addition to its location, why that's important. It's also important because Black churches actually ameliorate the medical mistrust gap between Blacks and whites. I just talked about that Blacks are less likely to trust healthcare and why that is. It's a valid, rational reason. But the research I've done with Dr. Abigail Sewell, who's a professor at Emory, is that Black people who attend Black Protestant churches are more likely to trust healthcare, which means you can use the churches to get more people to that site for testing. So that, because see, when you talk about stats, it's build up a statistical base. I think two other things in the short term that could be done: hazard pay and paid sick leave. These are things that could be done very, very quickly that would allow people to get paid like they're putting their lives on the line, because that's what hazard pay means, and then paid sick leave to give people 2 weeks of reprieve so that then they can go get the care they need, they can get treated, and they can stay home and not expose other people.
Thank you. Thank you. That was actually very powerful, and it actually lets me know, for me, a little bit of that we're on the right path, trying to push for some of that stuff and having things in neighborhoods here, and know that we have to go even further. Have you seen any examples of government and community working together thus far in your work to reduce this gap, the racial gap, health gap?
Yeah, I think so. So I'll give you a few examples, and I'll even mention the digital divide as well, because we know that that's happening with schools. So I think when we look across the country, there are certain states that have done it better than most. Even though Maryland has a gap, I actually think that the state overall has done a decent job. In Prince George's County, it's interesting because, of course, we know outside of a couple of zip codes in Baltimore City, Prince George's County has the highest number of cases. I actually think what's happening there, and there are two metrics I'm gonna give people to think about. I think what's happening there is that more people, and then more Black people in Prince George's County, are getting tested. That's because they set up a large facility at FedEx Field, which sits in between a more affluent area and a lower income area. Part of what that means, everyone can access it. Now, the reason why I think this is simply about people getting tested and not about Black people dying is because when you look at the number of Black people who have died in Prince George's County up to this point, it's similar to other counties. It's similar to Baltimore, it's similar to Montgomery County. If it was about people dying, we would expect that the higher number of people being tested would correspond to the higher number of people dying. We're not exactly seeing that match. So this means it's about testing, and it's because testing is in a Black community. I think Ohio has done a good job. I think California has done a good job, and I think Austin, Texas has done a good job. On the digital divide front, one thing Austin did, and one of my colleagues at Brookings, Dr. Nicole Turner Lee, had a great article about the digital divide. One thing she recommended was to outfit school buses with Wi-Fi. So this becomes the public-private partnership. Is to get, Xfinity, to get Comcast, to get all these different companies together, AT&T, to build together and outfit school buses. And then you put those school buses on their routes. And now all of a sudden you give kids the tablets that you're talking about. Now all kids can access Wi-Fi, because in a lot of cities, about a sixth of kids, sometimes up to 20%, don't have Wi-Fi access. They can't even do their work. So that's a good thing. In Detroit, of course, we know there are a lot of issues with Michigan. I mean, 70% of the people dying in Michigan are Black. I mean, that's just atrocious in a state like that when we talk about Detroit and Flint. One of the things they've done, though, is they've partnered with people to actually start having testing facilities in predominantly Black neighborhoods. One of the big things that they did in Michigan and in Ohio is they formed task forces to center around the racial gap. And they essentially called it a health equity task force, which means we're going to get all these people together to figure out how we can layer up resources. I think that's extremely, extremely important. So I think those are examples across the board that can be utilized to say, all right, what can we do in cities to bring forth public and private partnerships to get people these testing resources they need and then triage they need quickly. Because as we know with COVID, typically takes 5 days before the symptoms really start hitting. And then you have like another 10 days when I mean it's just ravaging your body. So these things need to happen quickly.
Yeah. Thank you. Thank you, thank you. I think that's critical, critical information. And listen, we have to work together on across government, community, being very innovative, understanding the needs, having the data is critical. And here at the city level, I push for that. But now we have it, we have to take it to the next level and making sure that we use that. Well, now we're on with that data to actually have the impact, as much impact as we can have with that data. Something I want to talk to you about. And this is something that I pushed here at the city level. And we know people are asked to wear masks when they're on public transportation in stores. But many of us, many black men though, are concerned about treating like they're a threat if they are wearing a mask. How have you? I know I've had conversations with folks and let people know here that if anybody, any business, any person that's not allowed, they're a black man, they tell them to take their mask off when they go in the store to let me know personally, and I would deal with that individual establishment. But how have you heard about black men navigating that? As we know that historically, a black man with a mask is like the most dangerous creature known to man when you think about American society. How have you heard about people navigating this, the need to wear masks for a public health standpoint in this public health emergency like we've never seen, but also the historical fears of the black man?
Yeah, I mean, I think black men are worried. So, I've written about this. I did a Washington Post video op-ed that people could tune into, essentially responding to Surgeon General Jerome Adams, essentially talking about wearing these masks. And as I mentioned, I've done a lot of research on physical activity and race and place. And so it's a few things going on. First thing, of course, black men, their worry is rational. And I've talked to a lot of black men who talk about kind of a pre-conversation that we were having, which is that when I go out, I need to make sure that the mask is flashy. I need to make sure that it's orange or it's pink or it has some kind of design on it. One of my colleagues in Maryland, Dr. Stephen Thomas, he had a cow mask, like just doing anything to try to indicate. I've known men who've had smiley faces on their masks. They've gotten their kids to make the mask, just trying to alleviate that threat. Because we know, unfortunately, that blackness becomes criminalized. And we know in cities like Baltimore, there's a history there, a recent history that I think black men worry about. And of course, then black women and other people in the family worry about them going out. So I think that's the thing about the mask. The thing is, though, is of course, being black in America, this is something that black men have always done. We go through what's called a signaling process. We even do this when we try to engage in physical activity, particularly when we're in predominantly white neighborhoods, trying to indicate that I'm here trying to help, not to hurt. And it's interesting with masks because when you're in a store and you're being told to take your mask off during a pandemic, I mean, that suggests that the people asking you to take your mask off does not care about your body and your humanity at all. It instantly tells you where you are in that moment, oftentimes being at the wrong place at the wrong time. I oftentimes like to say being in the right place with the wrong skin color based on who you're interacting with. And so part of what it is, we engage in a signaling process where we do things like when we're trying to exercise, like wearing an alumni t-shirt if we went to college, wave and smile at our neighbors, always have our IDs on them. And this is what's key. This goes across the socioeconomic status. This happens for you, even as a city council president. This happens for me, even as a professor and a fellow at Brookings. Some kind of way we make the assumption that only low-income black men are doing this. Unfortunately, there is a linked fate with blackness that leads to us enacting these sort of things this way. And it's unfortunate because this can impact our mental health and our emotional health. It can increase our stress level, our depression level, our anxiety level. And then all of a sudden, those mental health stressors can manifest in us physiologically to start impacting our physical health, increasing our blood pressure, increasing or messing with our blood sugar, increasing our likelihood of stroke. So when we talk about a mask and we hear things coming out from the White House and the Surgeon General, there was a lack of context there to actually talk about the sort of things that needed to be done to try to protect all citizens and not just some citizens.
Yeah, I think, and look, man, I think that you're spot on that, right? And I'm just going to be open and transparent. I've been waiting for somebody to tell me to take my mask off. It hasn't happened as of yet. Been waiting for someone to say that, because I think when you're in a position like I am and you have the ability to stand up for people and do things that others don't, then you have to do that. So this is something that we have to consider. And again, if anybody's being told in Baltimore to take your mask off in a place of business, please let me know, because we will definitely follow up. The last thing I want to ask you before we turn it over to viewer questions quickly is actually the most important question. I want to ask you, how are you and your loved ones, your family, during this tough time? Thank you to your wife for all of her great work. But how are you guys coping with COVID-19?
I think we're coping very, very well, relatively speaking. It's two things that I always think about. First, doing the work I do, and the vulnerable people and the oppressed people that we essentially just talked about. And I put that in perspective to the fact that I'm blessed to be in the house and work at this time in this way and be able to be at home and homeschool my kids. I consider it a blessing. So while there are a lot of people who are tired of homeschooling and tired of being in the house, I view it completely differently. I view it as a blessing and an opportunity to reset, opportunity to think about what's important, an opportunity to think about how you can help. Of course, this is one of the ways that I help. An opportunity to engage with your kids to figure out what's new in their lives. What are they doing? And again, of course, the other side of this is being worried about my wife. I really don't think people know what they go through. Like when she comes in the house, she has to take her shoes and her clothes off at the door. She has to throw some clothes away. She instantly puts some clothes in the washing machine. She instantly takes a shower. She can't sleep in our bed. She's sleeping in another part of the house. This has been going on for 6, 7 weeks. And so I don't really think people understand the way that our healthcare providers and frontline workers are putting their lives on the line. So, in the grand scheme, I'm good. I just want people to set goals, try to create some normalcy. That's one of of course, my kids' school helps me create normalcy, work helps me create normalcy. But I think overall, we can just try to see things from someone else's perspective, and hopefully we build a bit more empathy coming out of this.
Yeah, thank you. I think that's critical, man. And what I always say to people is that we have to, if one thing that we take positive from this experience is that we have to spend more time appreciating people, our workers that we normally don't, but also the time that we spend with our loved ones and people that we care about directly. So, just a couple questions. Let's see if you have more questions. Get them in. There's a question from James. So, did we extend the emergency declaration? We passed a resolution that will allow for that to happen. Yes. Another question around, can we extend unemployment? As you know, that is something that's done at the state and the national level, but we're going to continue to fight and advocate for that. The next question was, this a question, what can we do to create more community health centers? Again, this is something that we have to consider as we go into implementation of the equity assessment law that will come into law in July, but also as we're working with our partners to create these centers across and work with our health partners to create things in areas where they need. And in Baltimore, where we have these large health institutions working to make sure that they are doing work through a lens of equity in the neighborhoods that they're in, making sure that they're reaching out and understanding how they can undo some of that bad blood that's been built up over the year. Next question was, how do I feel about Como's decision to make testing available to essential workers who've been on the front line every day? I think that it's critical that we're doing that. Again, no one has the amount of testing that we need. We know here in Maryland, the governor has went out and got 500,000. We're going to be working at the city level to see how that's going to be rolled out in jurisdictions, so that we can expand testing, because we know, again, testing, tracing, and analyzing, as the good doctor said, is critical to how we're going to deal with this crisis moving forward. Next question was, do I think the current White House administration is downplaying testing assistance to states to evade disclosure of the number of positive COVID-19 cases and the impact data would have on the public before the election? I just simply think that they're public health professionals that are trying to do the right thing, but they have a leader in the president who is not fit to be the leader of this country, who does not understand the situation and how deep it is, the situation, who's thinking more about his pocketbook and the pocketbooks of his friends, right? Their wallets, versus the health of the American people. And that's why I say to you guys time and time again, Listen to the advice of the public health professionals. Listen to the folks at your local level, at the state level, who are always going to be following that advice, and understand that in the White House right now, you don't have someone that has your best interest in heart. And when you think about the bleach and the Lysol and all these other comments that have been made, you know that that person should not be listened to during this crisis. Dr. Ray, I want to give you any last words that you have for Baltimore before I close out. Thank you. And I want to say thank you on behalf of the entire city of Baltimore. We would love to talk to you more. I'm gonna have some more questions for you after our hearing tomorrow that I will send to you. But any last words for the citizens of Baltimore who greatly appreciate just by looking at the chat that we have on the live feed, who greatly appreciate your time and the information you've been able to give to them.
I mean, I just want to say, look, I love Baltimore. I'm raising my kids here, and I think this is a great area. I just want to lastly say there are a lot of us, a lot of workers who can't go to work. I'm thinking about barbers. I'm thinking about hairstylists. I'm thinking about dry cleaners. Think about sending them a little bit of money if you have it. I mean, it doesn't have to be a lot. 5, 10, $20 can go a long way. If 5 people give one barber $20 each, that's $100 for him or her to put food on their table. So I think it's a lot of ways for us to give. If you have an extra laptop, be in contact with an organization of the city to figure out how you can get it to a kid that hasn't been able to partake in class. So I think it's a lot of things that we can do to mobilize the everyday resources we have.
Thank you. And as we end, I want to remind everyone that right now we are dealing with the COVID-19 crisis, but I want to remind everyone to and ask them to ask themselves, where were you 5 years ago today? Because we know that 5 years ago today, our city erupted into unrest following the unfortunate tragedy of the death of Freddie Gray. And while there is still a lot of work to be done, to repair Baltimore. And we understand, as we talk about with the good doctor tonight, that many of this long-term and long-standing systematic inequality was there long before the unrest and was just exposed with the unfortunate death of Mr. Gray. But we have to understand, for all the progress that we've made, we still have much more to make in the city of Baltimore. We still have to deal with inequity, overdose, gun violence, all the things that lead into that, like we were talking about, the structure that leads into that. And now we also have to deal with this global pandemic of COVID-19. Baltimore, we are a city that's more resilient and resilient like no other. Whenever they count us out, we always overcome. We will do this together. We will overcome together all the issues that Baltimore has. And we just want you to know that we're going to continue to fight each and every day to make Baltimore a better place and hope that we all can do that together. So, Doctor, thank you again. Please remember to stay safe. Make sure that the family stays safe and healthy. And we look forward to talking to you again in the future.
Thank you. Praying for you and your mom.
Thank you. Thank you.